name's Hayley Harwood, and today I'll be talking to you about the pharmacological and surgical interventions for obesity and their effects on client health outcome. As obesity is classified as a chronic condition that requires persistent and sustained management efforts, mounting evidence supports use of pharmacological and surgical interventions to not only ameliorate comorbidities, but also amplify adherence to behaviour changes and improve physical functioning. Generally, pharmacotherapies that are approved for long-term obesity management have produced approximate mean weight losses of 5 to 15% over 1 year, and on average, weight loss with bariatric surgery is greater than with non-surgical interventions in the range of 15 to 35% depending on the procedure. It's really important to note at this stage, though, that these tools are most effective when used as adjuncts to behaviour modifications. So my objectives for today, I'll be speaking to you about the main obesity drugs and their effect on primary endpoints, specifically type 2 diabetes, the main obesity surgical procedures and their effect on primary endpoints, remarkable findings for gastric bypass surgery, and conclusions and practical implications. It is recognised that all therapeutic interventions are associated with at least some risk of adverse effects, and the benefits of such therapies need to outweigh the risks. In 1991, the NIH established guidelines for patient selection for therapeutic interventions. However, these guidelines consider neither age nor comorbidity severity and were developed over 25 years ago. With surgeons now operating at the extremes of age and BMI, it's evident that there's a need to expand the indications for surgery especially. In saying all of that, the loose guidelines within the literature state that a person with a BMI of 25 is suggested to utilise exercise or behaviour modification. BMI of 27 plus a comorbidity suggested to utilise pharmacotherapy, and that of someone over 30 BMI. And a BMI of 35 plus comorbidity is suggested to undertake bariatric surgery, or a BMI of over 40 is suggested to utilise bariatric surgery. So obesity and related comorbidities include diabetes, hypertension, dyslipidemia, sleep apnea, and low quality of life. Type 2 diabetes and obesity are closely interrelated chronic conditions, with abdominal adiposity particularly tightly linked to induction of insulin resistance and insulin secretory defects. Therefore, for the purpose of this investigation, I've chosen to focus my efforts on this area. By attenuating the mechanisms that promote or contribute to weight gain and maintenance, weight loss medications may help individuals manage physiological barriers that can impede other approaches to weight loss. So when reviewing the literature, it's evident that pharmacological interventions successfully yield greater weight loss when used as an adjunct to behaviour modifications. So currently there are 5 distinct medications approved for long-term weight management in the United States. They are Orlistat, combination phentermine and topiramate, leucovorin, naltrexone, and bupropion, and liraglutide. It is important to note that Orlistat is the only medication in the European Union for chronic obesity management. However, in the US, phentermine is currently the most widely prescribed weight loss medication, which is likely a reflection of the low cost as compared to other weight loss medications. Therefore, for the purpose of this presentation, I'll be focusing the research surrounding Orlistat and phentermine and topiramate. So, number 1, Orlistat is a gastrointestinal lipase inhibitor that prevents fat absorption. It's administered as a 120 milligram dose 3 times a day within 1 hour of a meal, and this prevents absorption of 30% of triglycerides in the stool. Phentermine and topiramate. Phentermine component acts on the POMS neurons to suppress appetite, and they're critical regulators of food intake. Although it's not clear how the topiramate suppresses appetite, its effect has been shown to be addictive when used in combination with phentermine. So the starting dose is 3.75 milligrams, and after 14-day intervals, it's increased to 7.5 milligrams, and the top dose is 15 milligrams. So this graph represents data on a one-year weight change study by Apovian, Garvey and Ryan in 2015. As you can see, all 5 drugs induced weight changes from 3 to 6.6% of initial weight, with the most pronounced changes seen with the use of phentermine and topiramate. So seen here was a mean weight change of 6.6%. It was also the most effective with patients losing more than 5% and more than 10% of initial body weight. So just to compare, a review of 15 studies using orlistat for the treatment of obesity yielded greater results. So that found after 1 year of use, mean weight loss equaled 10.9% of initial weight versus 1.6% placebo. Weight loss of at least 5% of initial weight was 67%, and weight loss of at least 10% of initial weight was 47%. So it's been stated that sustained loss of 5 to 10% of body weight in obese and overweight patients has proven to be effective in preventing progression from pre-diabetes and metabolic syndrome to type 2 diabetes. It also amends the cardiometabolic disease process, as shown by an increase in insulin sensitivity and a reduction in cardiovascular disease risk factors. In a 4-year double-blind prospective study, 3,305 patients were randomized to lifestyle changes plus either orlistat with 120 milligrams or placebo 3 times daily. Primary endpoints were time to onset of type 2 diabetes and change in weight. So after 4 years treatment, the incidence of diabetes was 9% with placebo and 6.2% with orlistat, corresponding to a risk reduction of 37.3%. So differences in diabetes incidence was detectable only in the impaired glucose tolerance subgroup, as weight loss was similar in subjects with normal glucose tolerance or impaired glucose tolerance. In patients with impaired glucose tolerance at baseline, orlistat plus lifestyle changes significantly decreased the progression to type 2 diabetes when diagnosed on the basis of a single test. So Garvey and colleagues in 2014 found similar results with the use of phentermine and topiramate plus lifestyle modifications to produce significant weight loss and markedly reduced progression to type 2 diabetes in overweight and obese patients with pre-diabetes and metabolic syndrome. In patients with pre-diabetes and or metabolic syndrome, phentermine and were highly effective in inducing and sustaining weight loss and had a profound effect on prevention of type 2 diabetes as measured by cumulative and annualized incidence rates. There was a 79% reduction in progression to type 2 diabetes among patients treated with the highest dose of the drug. Both orlistat and phentermine and topiramate have been shown to be effective in improving cardiometabolic disease risk factors. For example, orlistat plus lifestyle changes result in an early and significant improvements in cardiovascular risk factors, including blood pressure, waist circumference, and lipids. Total and LDL cholesterol and the LDL to HDL cholesterol ratio have been shown to decrease significantly more with orlistat than placebo. Phentermine and topiramate have also established improvements in cardiometabolic disease risk factors in subjects with prediabetes and or metabolic syndrome when compared with placebo. The fasting glucose, fasting insulin, fasting triglycerides, and HDL cholesterol have all shown marked improvements. As previously stated, it is recognised that all therapeutic interventions are associated with at least some risk of adverse effects. Adverse events and complications are common in clinical trials and can lead to discontinuation of the studies. For example, gastrointestinal episodes were the most common adverse events associated with orlistat use in clinical trials. So we saw 20% of patients being affected by gastrointestinal episodes, and 8.8% discontinued treatment due to these adverse events. Phentermine and topiramate saw discontinuation rates due to adverse events were 11.6% to 17.4% across the different doses, where nausea, headaches, dizziness, and vomiting were common complaints. Bariatric surgery. So there are 4 type operations that are commonly offered, which include adjustable gastric band, gastric bypass, biliopancreatic diversion with a duodenal switch, and vertical sleeve gastrectomy. So the gastric bypass surgery is the most commonly performed in the United States, followed closely by the sleeve gastrectomy. So for the purpose of this presentation, I'll be focusing my attention on those 2 procedures. So the gastric bypass restricts food intake and decreases how food is absorbed. Food intake is limited by a small pouch and then sent from the pouch into the small intestine. The food is then absorbed differently because the stomach, duodenum, and upper intestine no longer have contact with food. The vertical sleeve gastrectomy restricts food intake and decreases the amount of food used. So most of the stomach is actually removed during this surgery, which may decrease ghrelin, a hormone that prompts appetite. Lower amounts of ghrelin may reduce hunger more than other purely restrictive strategies. So it's been demonstrated that compared to non-surgical treatments, bariatric surgery leads to greater weight loss, higher rates of remission of type 2 diabetes and metabolic syndrome, greater improvements in quality of life, and greater reductions in the use of anti-diabetic, anti-hypertensive, and lipid-lowering drugs. Massive weight loss and reduction in adipose tissue mass clearly contribute to the major improvements in insulin sensitivity and cardiovascular risk profile observed after bariatric surgery. On reviewing the literature, it's evident that significant improvements in type 2 diabetes, as seen by the reduction in glycated hemoglobin levels, can occur after bariatric surgery in obese patients with advanced diabetes. The primary endpoints of recent studies is to achieve the therapeutic target of glycated hemoglobin levels of 6% or less in 12 months after treatment. A study by Shua and colleagues in 2012 evaluated the efficiency of intensive medical therapy alone for medical therapy plus gastric bypass or sleeve gastrectomy in 150 obese patients with uncontrolled type 2 diabetes. There was a large and rapid improvement in levels of glycated hemoglobin and fasting plasma glucose after each of the surgical procedures. The proportion of patients with the primary endpoint was 12% in the medical therapy group versus a whopping 42% in the gastric bypass group, and also 37% in the sleeve gastrectomy group. Similarly, a 3-year follow-up study identified that bariatric surgery was associated with superior and sustained glycemic control and weight reduction when compared to medical therapy alone. A sustained decrease of 2.5 percentage points in glycated hemoglobin over the 3-year period was seen in the surgery group, compared to 0.6 percentage points equal therapy group. The results of surgery are particularly striking in this population with relatively long-standing uncontrolled disease. So this figure is just reiterating the large improvements in glycated hemoglobin, fasting plasma glucose, changes in BMI, and reduction in medication seen with gastric bypass especially. Furthermore, a meta-analysis of 11 studies and 796 people found bariatric surgery patients had a higher remission rate of type 2 diabetes. That's a relative risk or probability of event occurring of 22.1, and also metabolic syndrome with a relative risk of 2.4. It's also important to note that diabetes remission began within days to weeks after surgery, before substantial weight loss occurred. This rapid glucose lowering, disproportionate to the degree of weight loss, suggests that bariatric surgery, specifically gastric bypass, reverses the pathophysiological defects of type 2 diabetes. Beta cells are unique cells in the pancreas that produce, store, and release the hormone insulin. The progression from normal glucose tolerance to diabetes is characterized by reductions in beta cell mass that in turn lead to impaired beta cell function. A recent study by Kashyap and colleagues in 2013 observed striking metabolic changes in gastric bypass patients who exhibited poor pancreatic secretory function at baseline. After both 1 and 2 years of follow-up, gastric bypass patients achieved near normal glucose tolerance after a physiological liquid mixed meal. These effects were associated with a remarkable 5.8-fold increase in overall pancreatic beta cell function. In gastric bypass patients, both insulin sensitivity and secretion components increased. But despite comparable weight loss in sleeve gastrectomy, insulin sensitivity was only partially restored and pancreatic beta cell did not improve. This suggests factors specifically linked to the presence of abdominal or truncal fat. It is therefore suggested that beta cell function, not insulin sensitivity, is the key determinant of postoperative glycemic control. It's also argued that the duration of diabetes alters the effects of bariatric surgery and is an important clinical factor in predicting disease resolution. So Kana and colleagues in 2015 found that enhanced beta cell function characterizes the effect of bariatric surgery in adults with short-term diabetes, so less than 5 years, which is independent of weight loss and incretins, which is a metabolic hormone that stimulate and decrease the blood glucose levels by causing an increase in the amount of insulin released from beta cells. However, additional therapy post-surgery may be required to improve glycemia for longer duration or greater than 10 years type 2 diabetes. So secondary endpoints including BMI, body weight, waist circumference, and the insulin resistance index also showed more favourable results in the surgical groups than in the medical therapy group. So this graph is derived from a study by Schuer and colleagues in 2014, which shows weight loss was greater in bypass and sleeve gastrectomy group, 24.5% and 21.1% respectively, than in the medical therapy group, 4.2%. So here we have an analysis of secondary endpoints after 3 years in the surgical groups, as compared with the group receiving intensive medical therapy alone. So patients in 2 surgical groups had a significant reduction in the use of antihypertensive and lipid-lowering agents, even though there was no significant changes from baseline measurements in blood pressure or LDL cholesterol among the 3 study groups. Here we can also see an increase in high-density lipoproteins. So the most common adverse events after bariatric surgery were iron deficiency, anemia for individuals undergoing malabsorptive bariatric surgery, and also reoperations. There was also reoperation to assess nausea and vomiting, and also to treat a gastric leak after sleeve gastrectomy. So just to reiterate the main points of this presentation, pharmacological and surgical interventions are effective in the long-term management of obesity. However, these interventions should be used as adjuncts to behaviour modification. Oralist and phentermine and topiramate improve patient comorbidities, incidence of type 2 diabetes, and metabolic syndrome. Also, gastric bypass uniquely restores pancreatic beta cell function. Practical implications. So medications act to amplify the effect of the behavioural changes to consume fewer calories. They do not work on their own. To get maximal efficiency, obesity drugs should be used as adjuncts to lifestyle change therapy, and in some cases, weight loss is limited without lifestyle change. Therefore, EPs need to educate patients that lifestyle changes are needed when using a weight loss medication, and that the addition of a weight loss medication to a lifestyle program will likely result in greater weight loss. EPs should monitor clients' weight loss. They need to be aware of the guidelines of effective and safe utilisation of obesity medication. Most studies have shown that initial weight loss response at 12 weeks predicts later weight loss at 1 year and afterward. Therefore, if a patient does not lose at least 5% of initial weight after 12 weeks of therapy, that patient is more likely to be exposed to the risks and costs of drug treatment when there's little prospect of long-term benefit. In these instances, EPs should work together with clinicians to discontinue the use of such obesity medication. EPs should be aware of the common adverse effects, differences in dosing, and limitations regarding use in specific populations in order to appropriately advise patients of their options and educate them regarding the therapeutic choices. Additionally, EPs should recognise that there is variability in individual responses to agents, and medications should be used at the lowest effective dose. EPs need to be aware of the best and most recent evidence, including current treatment recommendations and new therapeutic options. In addition to identifying the need for treatments, EPs should assess disease severity to identify appropriate individualised obesity interventions. Thank you very much.